Although the meeting is being recorded in the English audio channel only, the slides from today's presentations are available in both English and Spanish. Please follow the links provided in the chat for copies of today's presentations. Please email me at holly.jessup@arb.ca.gov if you need assistance accessing these materials. All participants except the speaker should be muted. Please remain on mute. When you have questions, please enter them in the Zoom chat window. The icon to access the Zoom chat window is shown on this slide. Clicking on this icon will lead to a dialog box where questions can be typed in. All questions from the Zoom chat will be collected and I will present them to the speakers during the Q&A session at the end of today's presentations. If we do not have time to address some questions, written responses will be provided. Next slide. So please include your email address in the chat. Lastly, if you would like to be kept updated on this research contract, please enter your email address in the chat. Or please email me to be added to our email distribution list. Next slide. Next slide.
Well, actually, I'm getting a message from the interpreter. I appreciate if you can assign me as an interpreter. I don't have to.
One moment. I thought I had.
Okay. Thank you, Pat. Thank you, Holly.
Okay.
Thank you. One moment. From English. Okay, Aldo, I believe that's set now. Let me check. Yes, I believe that's taken care of now, Pat.
Okay.
So slide 4. Okay, so let's get started. Today's agenda is that I will be beginning this research contract kickoff with a very brief introduction to the project, and then we'll introduce today's speakers. Today's first speakers will be a representative of CCV who will be speaking about the community collaboration and engagement aspects of this project.
Sorry about that for some reason.
It's okay.
I got a pop-up happened. Okay.
CCV will then be followed with a presentation by the principal investigator and his team. And then I'll conclude these two presentations with a very brief overview of the project's next steps and the timeline for future updates. So next slide. So lastly, as time permits, I will present to the speakers any questions that have been entered into the Zoom chat. If you would like to be sure that you receive an answer to your question, whether during today's meeting or later in writing, please enter your email into the Zoom chat along with your question. Next slide. So this project's overall goal is understanding and systematically tracking improvements to community health data and trends that can be linked to air pollution levels. That is, the project's aims to address the question, how are health conditions linked to air pollution changing over time, with a focus on California communities that are highly impacted by air pollution. Both communities and the scientific community have repeatedly expressed a strong need to understand health conditions linked to pollution and how these conditions are changing over time. Under this project, the contractor will first work in selected areas of the state to develop a comprehensive health tracking system that can be accessed by community members to see health indicators and how they are changing over time in their areas. All the data and information generated will be tabulated and displayed in an easy-to-use web-based dashboard, which will be digested in the established Tracking California website. Next slide. Second, the project will also develop and apply a causal modeling framework to assess air pollution benefits in communities. That is, the investigators will be using a specialized statistical approach to assess possible health improvements from interventions to air pollution that have occurred in specific communities. Next slide.
Before going to the next slide, I'm getting some questions about downloading the slides.
Okay.
If everyone who wants to download the slides, just scroll up in the chat. Both the slides for Holly's presentation and the UCLA's presentation in English and Spanish are available there. So just go to the chat and scroll up if you want a copy of the slides.
Thanks, Pat. So with that, I'd like to introduce today's speakers. First, we are welcoming a member of CCV, Mr. Christian Torres. He's a graduate from California State University, Northridge, and is a special projects manager at CCV, where he's working towards providing the Imperial Valley community with quality environmental data to aid in local decision-making. Along with Luis Olmedo and Tracking California, Torres will lead efforts to coordinate community participation, review of project results, and coordinate the development and translation of outreach deliverables for the public for the project. After CCV's presentation, we will be hearing from the principal investigation team being led by Dr. Michael Jarrett of UCLA's Fielding School of Public Health. Dr. Jarrett is a professor and chair of the Department of Environmental Health Sciences and is an internationally recognized expert on how to characterize population exposures to air pollution and built environmental variables, how to understand the social distribution of these exposures among different groups, and how to assess the health effects from environmental exposures. We will also be hearing from Dr. Paul English, who is Director of Tracking California, a program of the Public Health Institute. Dr. English was principal investigator of the Imperial County Community Air Monitoring Network project, which was the inspiration for AB 617. Lastly, we'll be hearing from the PHI subcontractor, Dr. John Molitor, who is an associate professor of biostatistics at Oregon State University. He has extensive experience examining spatially varying effects of air pollution exposures on marginalized subpopulations. So with that, we'll pass it over to our research team.
So next slide, please. So the overview has already been given by Holly. So in the interest of time, I'll just move to the next slide. And I want to turn it over to Christian Torres of Comité Civico de Valle.
Thank you, Dr. Jarrett. Good morning, everybody. Glad to see so many familiar faces in this group that I've worked with alongside the last couple of years. So here at CCV, I wanted to give an on-the-ground perspective, given the experience that we have working on the 8617 program, through the Imperial project to the implementation of the 8617 locally here in Imperial, as well as in the Eastern Coachella Valley, which were the two communities that we participate, as well as the technical assistance that we have given groups across the state who have become 8617 community grantees. A lot of the communities selected for the program already suffer disproportionate burdens of pollution, being environmental justice communities, where industry, the environment, and other issues have systemically already created environmental health problems within those populations. And in a lot of those communities, health tracking data is not the best as it is to more well-off communities or communities that are more near metropolitan areas. A lot of the rural areas that suffer from environmental health problems are doing so because they have not always had that data that backs up requests for them to be able to have assistance. And the System Center program that is trying to help with that, with not only capturing emissions data, doing those emissions inventories that come with those 8617 communities, but also with the air monitoring data that a lot of those 617 air monitoring communities are able to collect. Across the state, from the work that I've done across different 617 CS community steering committees, air grantees, and just convenings like the one that UC Davis and Carb put together for the last couple of years. I've heard so many advocates, community organizations, health professionals who sit on these committees that participate in the program and have long known a lot of these issues based on their lived experiences in their communities, and that they see the program as a way to finally address some of these issues. But again, because the program implementation, and we can all be honest here, was a little rocky in the beginning, they're finding it harder to engage, but they are still engaging and hoping to improve their communities. And they want to, because they've lived there, they live there, and they want to be able to have their kids and their family and friends be able to not have health issues. And as I said, the program isn't perfect, but it is a gateway to improving air quality and public health in a lot of these 617 communities, and also showcasing lessons learned from a 617 community to other communities that suffer from mental health issues, where you can transfer those strategies. It's been a statement that's been said by consultation group members, by CBOs in the air grants programs, where if you can design a strategy that works for a specific issue, you should be able to transfer those to other communities that are not selected for the 617 program. As you know, the funding is limited, and only a handful are added year on year. We can go to the next slide. So what have we heard? The data gaps affect public health. Here at CCV and Imperial, and as well as in Coachella, where we worked on community research projects, we know that there isn't enough health data available. A lot of the health data that we do have is either at the regional level or it's at the county level, which doesn't always help us identify specific communities that have a specific issue. We've also heard that emission reductions will affect public health outcomes. We have as a member of our community steering committee in Imperial, Dr. Khan, who was always worried because she used to treat a lot of kids with asthma coming into the emergency room, and then she had to open up her own practice to be able to specialize in that issue. And she was treating kids from all over Imperial County. So, and in Imperial County, you know, we have one physician per 4,000 individuals, which is twice as much as is recommended or the standard across the U.S., which is 1 per 2,000. So she was very adamant when joining the 617 steering committee that she was there to learn what the issue was, because she knew that there had to be an underlying issue for how many increased asthma cases she was receiving year on year for being in Imperial County. We've also heard that folks want to incorporate the work that's already been laid down. So a lot of the community-based organizations have done air quality monitoring, have done health studies, and have done a lot of surveys with community members for years. So a lot of them have the groundwork already laid out as the program was being designed and when it came into implementation. But I think mixing that work into the startup of 617 was a bit rocky. Not all communities took on the EJ work that had been done beforehand. And I think as the program's evolved the last couple of years, we're seeing more implementation. We saw the redesign of the blueprint, right? Like right now, there's a people's blueprint that's being worked on, discussed by the consultation group, as the program has to implement changes moving forward. And a lot of those emissions reduction and community monitoring plans are also evolving as programs going along, and communities are collecting better data, more granular data, and they're deciding their strategies to tackle specific issues. Next slide. And these are some examples of the groundwork that's already being laid out, as I mentioned. The 617 leadership, you know, at Imperial, we created a charter and a governing structure that some of the other 617 communities are now borrowing, which is a co-community leadership structure where you have a community group or a community leader co-lead the 617 efforts locally with the air district. There's a lot of programs that are in specific communities that suffer high asthma rates or respiratory issues, such as in the San Joaquin Valley, in Imperial, and these Coachella. And these programs, you know, go hand in hand with being able to track the air quality data and then also provide a mitigating solution. So a lot of these are intervention programs that provide services directly to families most affected by this that don't have access to quality healthcare. There's also Carb research collaborations. So this is one of the projects that I'm working on. I'm also working on a research project here in Imperial with San Diego State University, which is to find research priorities in regards to air pollution in the Imperial Valley. And tying in those efforts will go with this as well, because we have a lot of background data, but there's still a lot missing. And hopefully with the health outcomes or the health tracking data that we were able to find in this project, we can inform some of the efforts that are happening in the other one and work by, and we want to be able to synthesize those efforts as well. The community air grants, as many folks here at Carb know, are a gateway for a lot of the groups to be able to do groundwork or expand the work that's happening in those 6 and 7 communities, whether it's community monitoring, now designing emissions reduction plans or monitoring plans, and also preparing communities to join the program in later years. And there's also SEPs. SEPs have been, the supplemental environmental projects have been able to add resources we're missing in 6 and 7 communities. In Imperial, we were able to leverage SEPs to be able to finalize air filtration programs in a lot of the schools within the 6 and 7 corridor, as well as those outside the corridor, which didn't qualify through the 6 and 7 program. And the advocacy efforts that we're all making on the community. And, year on year, we're always going to the legislature and trying to make sure that the 6 and 7 program gets enough funding or more than it already's been allocated, because we know that the program needs more resources. We understand that air districts have to manage, in some cases, multiple communities, right? South Coast, which is one of the bigger air districts, I think has now 5 or more 6 and 7 communities, but the funding isn't always reflective of that. And we know that as we bring in more communities, there's also a lot more legwork that needs to be done, because not all communities have a Comité Cívico or a CCJN or a West Oakland Environmental Indicators Project locally. So they have to be able to bring in those expertises from the outside to help them at least start up the program. And here I'm showing you actually a picture of our EJ Summit, where you see community leaders across 6 and 7 communities in the state, as well as when we did the installation of our first EV 6 and 7 community monitor at the Air District office here in Imperial County. So there's always room for collaboration and room for sharing lessons across the state to be able to make the AB 6 and 7 program succeed more. Next slide, I believe, is moving on to the research team.
Great. Thank you so much, Christian, for that excellent overview and for all the great work that you and Comité have been doing over the years. It's been really a pleasure to work with you for, I think it's now more than 10 years since Dr. English started his project to put out the first community air monitoring system in the world in the Imperial Valley. And it's been great to see you evolve in such a leadership group. And we're very pleased to be working with you on this project. Just to give you a little bit more context on the project, as was mentioned earlier, we're attempting to develop a comprehensive health tracking system, and we want it to be both scientifically valid and responsive to community concerns. And we'll go through what we consider to be scientifically valid as part of our presentation. And where possible, we're going to develop zip code scale estimates of rates of disease and death. And I want to emphasize that we're not just focusing on the AB 617 communities. Through our collaboration with Dr. English and his team at the Public Health Institute, we are able to access statewide health data. So where possible, we're going to be computing estimates of health conditions that cover all areas in the state that are not suppressed due to confidentiality concerns. And then we're going to attempt to identify interventions affecting impacted communities, both AB 617 and other disadvantaged communities. And we're going to do this through an extensive consultation with community groups and with Air Resources Board staff, and also with local air boards, so that we can come up with an intervention that's going to be meaningful in terms of its policy impact, but also one that's going to allow us to use state-of-the-art so-called causal models or quasi-experimental models, so that we'll be able to look at whether or not regulatory policies are actually having a beneficial effect on community health. And that will always be controlled by looking at other communities that may not be affected by the same policy. So we'll cover that in more detail later as well. It's possible that we may not find that intervention that satisfies all of our aims. And in the event that that happens, we have some earlier studies that were done on the Goods Movement Action Plan that was implemented in 2007, 2008, that we'll use as an example so that we can build out the statistical framework and the health data so that things can be evaluated in the future. And as Holly mentioned, all the information generated is going to be displayed on an easily accessible web-based dashboard that'll be housed by Tracking California, which is led by Dr. English. Next slide, please. This just shows graphically the partners involved. So we have a team at UCLA consisting of Diane Garcia Gonzalez and Yu, who are both highly skilled postdoctoral researchers that have dealt with numerous health data and with website designs. And in Diane's case, with some very controversial community issues and related to unconventional natural gas development and natural gas storage facilities. So we have really terrific people at UCLA to work on this. And then Dr. English is going to be coordinating with Mr. Olmedo at CCV. We've included Dr. John Malcher, who's a world-leading expert in the quasi-experimental design models and also an excellent biostatistician for computing rates and proportions, which we'll be doing a lot of. And then we have Alexa Wilkie doing work on the administrative side. And then Catalina Garzon Galvez is helping to lead the public consultation, and Jacqueline Baye and Catherine Carpenter and Daniel Madrigal will all be contributing to the website development and the public consultation. Next slide, please. Just in case there are people that are not familiar with AB 617, it was a measure taken to protect communities that were disproportionately impacted by air pollution. And there are really two big significant components. One is that the air districts and communities are mandated to develop community-based air monitoring systems. And these have taken many different forms across the communities that are currently designated as AB 617, and they're shown on the map. And it also allows for community-specific emission reduction plans, so-called SERPs. So the SERPs can be used to target emission reductions in areas that are particularly a concern to the community or are likely to be generating health effects. Next slide, please. A really important aspect of both programs is that there has to be tracking of potential improvements to community health that result from emissions reduction programs. So at present, this part of the tracking system is not in place. And with the consultation that is going to be led by the Public Health Institute and Comité, we're going to be talking to people in AB 617 and other disadvantaged communities to find out what health tracking they want us to do, but also to help to share information with them about what we think is going to be a valid set of indicators for tracking health over time. Next slide, please. I'm going to now turn it over to Dr. English, who's going to give us an overview of some of the scientific considerations that we would take into account for developing health indicators.
Okay, thanks, thanks, Mike, and thanks, Christian, and good morning, everybody. So Mike has mentioned the project task 1 is developing a comprehensive and sustainable set of health indicators, and this would be based from administrative data. And we'll be reaching out to our community partner organizations, such as those serving on community steering committees, to ask their guidance for engaging AB 617 and other underserved and impact communities to develop neighborhood level metrics and data visualizations. And as part of this, I'll be working with my communication and outreach team at TRAC in California to develop an outreach plan and materials to engage the AB 617 Community Steering Committee members in selected communities and other community stakeholders in the project. So next slide. So on that, on the engagement, we're going to be convening 3 virtual regional meetings with community stakeholders in 3 regions, Northern, Central, and Southern California. And as part of that, we'll be sharing information on the health effects of air pollution and identify community health impacts of concern, and also discussing gaps in the neighborhood level health data and potential other community health metrics to include. Now, this slide is one that that me and Dr. John Baums showed to the AB 617 community steering committees, and I don't know, maybe it's been a couple of years ago now, but we started thinking about some of the criteria for health indices. And this slide shows you a kind of one of the measures, criteria, one that an ideal index should be proximal in the time to air pollution reduction. So if you have an emission exposure reduction, for example, we would see in proximal time a reduction in asthma exacerbations, for example, and then a reduction in asthma and respiratory disease cases, and then moving on to other outcomes such as a reduction in mortality from short-term exposures, heart disease, lung cancer, and then finally reduction in mortality from long-term exposures. Next slide. So this shows some other criteria for health indices, such as sensitivity. So the ideal index would be sensitive to changes in emissions exposure. Timely, the data would need to be available to evaluate the effects of pollution exposure reductions, preferably from public sources, accessible to all. And at a scale, we want it at a small area scale, census tract or zip code. And then the ideal index should be statewide and representative of California residents' health. And there's a number of statewide screening tools such as CalEnviroScreen, California Healthy Places Index, and others that could be considered rather than creating new indices. Next slide. And so this slide then shows you the different types of indices we considered as being good measures or indicators. And you can see I put together this chart that looks at all these different criteria, and nothing is really perfect. All the way from, actually biomonitoring populations, looking for markers of exposure or disease in human tissues, looking at pharmacy data, conducting surveys, doing syndromic surveillance, putting together a cohort. And as you can see in the last column, a lot of those candidate measures just really have a high cost. So really looking now at using administrative data that's publicly available that meet most of the criteria that we're looking at. Next slide. So we want to engage community members to gather information about their neighborhoods, including relevant environmental, social, political, and voting history. We'll be submitting agendas and notes from monthly planning meetings to plan and implement outreach engagement project activities, and conduct quarterly conference calls to inform planning and implementation of community engagement activities. And that's the overview of our piece from Tracking California. And I'm going to move it back. Well, let me just see. I have one more slide here. The next slide, please. Subtask 2. I think I've already gone over this, but we'll be really engaging these different communities to develop the neighborhood level metrics and data visualizations. Next slide. So this one shows you that the different types of inputs that we'll have for this project task. And these community stakeholders will include what we've called the ARI Collaborative, which stands for Allies in Reducing Emissions. And this has member organizations in Southern California, including Casa Familiar, Coalition for Safe Environment, and Comité Cívico de Valle, and the Central Valley, the Central Californian EJ Network at Northern California.
Wait, Rob, I'm
hearing some background noise. Okay, I'm unmuting myself again. So with this project, this slide then shows you we'll be getting input from our community stakeholders, contractors. We have technical resources, input from Carb, the ARE Collaborative I mentioned. We'll be gathering information about the community to inform our approach, sharing the language both in English and Spanish, conducting in-person on-the-ground networking, convening these virtual regional meetings I've mentioned, and getting input. And we're hoping our outcomes then will be increased community awareness about the community health outcomes. It will inform planning and build community relationships, identify these gaps, and identify community health impacts of concern and potential community health metrics to include, and receive community guidance on approaches to engaging communities. And the impact will be, we're hoping that the tracking stakeholders, the tracking data stakeholders will really feel ownership of the research and the tracking system, and we'll have public access to useful data that addresses the neighborhood priorities and data needs for decision making. Next slide. These were some of the metrics that we thought of as candidate metrics that we could track over time. And you can see they include illness metrics and death metrics, including conditions such as asthma, bronchitis, COPD, pneumonia, heart disease, heart attacks, and also all-cause diseases and deaths. These are all identified in administrative data by IC10 codes that we can pull off. Next slide. And am I continuing, Mike, on this, or you guys taking over?
I'm happy to take over. Thanks for that excellent summary, Paul.
Alrighty.
This is just some data that was compiled by Tracking California, and it shows the various rates of asthma, COPD, and myocardial infarction or heart attacks across the counties that contain the AB 617 communities. And for the most part, with a few exceptions like COPD and Riverside, which is lower than the state average, most of these are higher than the state average in general. But when we look at a very large area like counties, there are many things going on that affect exposures and health at a much smaller area, like a zip code or a census tract. And while we will present data like this, we're really going to concentrate on the small area data so that people can see what's happening where they live and to think about what that might mean to the health of their families. Next slide, please. This is a statewide map that we've created already to show the rates of pediatric asthma, so people under the age of 18. one thing that we've done with some of the rates is we've age adjusted them, because age is a major determinant of many health outcomes. So, and particularly with something like pediatric asthma, there's really a life cycle where little boys get it first, they resolve, and then little girls get more of it. So what we're doing is trying to look at data that is going to be most useful to the community, but also is going to have scientific validity. So these have been age adjusted for children less than 5, and then those from 5 to 18. And what you can see is that there's a lot of variability within some of the communities. Next slide, please. We've just shown the AB 617 communities in the Bay Area on the Oakland side. And you can see many of them do experience high emergency room visits for asthma. And but there are many other communities that are also burdened by air pollution and experiencing those very high emergency room visits. And these are age-adjusted rates per 10,000 population. So in some of these areas, you're getting 3,000 out of 10,000 people are being admitted to a hospital for asthma. Next slide, please. This is just another zoom in of the Fresno area and the Central Valley, which has several AB 617 communities. You can see that Fresno has very high rates of admissions. Again, not as high as what we saw in some of the Bay Area, but certainly there's a lot of variability going on within these communities. And you can see some of the other AB 617 communities where the rates really aren't that high. Next slide, please. And then this shows in Southern California some of the AB 617 communities, and we can see that there's a lot of variability where many of them are in that highest 20 percentile or quartile, the highest quintile, but some are not showing very high rates of asthma. And that's why we think it's important to be able to compare groups over time to control groups and to apply more advanced statistical models, because there are many things that drive the hospital for asthma. For example, lack of access to care could be one. It may not be due to air pollution entirely, or even partly. Next slide, please. And there are various ways that we can compute rates for these health outcomes. And you can see some of the limitations here, then some of the trade-offs that we'll face as we develop these indicators, is that a lot of the rural areas have small populations, so they don't have a lot of admissions, and these are all admissions for asthma. So the data are suppressed. So the public health department suppresses any data that's less than 11 counts in one of these small area spatial units. So it's still possible for us to compute rates, but we have to have a much longer run of data. But you can see we are picking up most areas where there are AB 617 communities and many other disadvantaged areas across the state. And we can also use the models that Dr. Molitor develops to look at things like the probability, the percent probability of having a rate that's greater than 1 or greater than 2. So we can begin to identify those areas that are really very likely to be experiencing high rates and try to understand why that's happening. So this is all very technical, but the main point is that we have a lot of variability within these areas. We have many different methods for dealing with it. And through the translational process, when we're engaging and consulting with members of the community, we want to know which of these methods you find most intuitive for helping to track health in your communities. Next slide, please. So this is just looking at some of the materials that we'll be developing and the documentation that we'll be submitting after we complete task 1 and it's subtask 2. So we'll be developing the outreach plan, and the community steering committee members will be selected, and we'll have other community stakeholders involved. We're going to write and disseminate plain language project materials that Dr. English talked about. They're going to be translated into Spanish and presented in English. And we're going to submit these outreach materials and conduct those regional meetings that Dr. English talked about. Next slide, please. And then this just goes into more detail about how we're going to summarize the data that's going to lead to our tracking system. And we're going to identify the data gaps at neighborhood levels based on what the community tells us, or the community members tell us, and on what's scientifically valid to develop for a health tracking indicator that's going to be responsive to air pollution exposure changes. Next slide, please. So this is another major task in the research, and that is to consult, as I mentioned earlier, with public air districts and air resources board staff to identify appropriate interventions, and by that I mean policies meant to reduce emissions and air pollution, and evaluate them with quasi-experimental tools with the aim of assessing where there are measurable health benefits that have resulted from these actions. And as I mentioned earlier, if we're unable to identify suitable newer policies to evaluate, we will use the Goods Movement Action Plan, which we've worked with before, using Medi-Cal data for people getting subsidized medical care. We'll expand that to look at outcomes that could be assessed with the administrative data on an ongoing basis, so that we can help community members understand how these models work, and then also to develop the statistical framework that we can use to better assess policies in the future. Next slide, please. So the quasi-experimental model is one that, as I mentioned, Dr. Molitor is a leader in the methods that are used to do this. But essentially what we're going to do is calculate rates of health outcomes. Most of the data that we're going to get from the administrative sources is at the zip code scale. And then we can compute rates that adjust against the statewide population or standard US population, or other populations in disadvantaged communities, so that we can look at how the rates in AB 617 communities differ from those that we might expect based on the age structure and of the standard population that we choose. So the reason that we do this is we want to see whether or not the population is experiencing higher rates of illness and death than what we would expect by their age structure. So this will result in this comprehensive set of indicators, but we can also take this information and develop models that are based on these quasi-experimental designs, which are broadly known as difference in difference methods, and look for these interventions that could be affecting AB 617 and other disadvantaged communities. And then we can use these models, which are very complicated, but they can be graphically shown to show people what would happen had the policy not been implemented. And I'll show you what I mean in a minute with another slide. Next slide, please. So this is from our Goods Movement Action Plan evaluation, and we looked at the rates of asthma that were people going to hospital for asthma, and basically what you can see here is we broke it up into areas where people lived with within a goods movement corridor, and then they also lived in areas that were outside of that. And we define that as 500 meters from a federal or state highway that was likely to have high levels of truck traffic. And when we see that the red line and the blue and the black, so the black is a control. So that's areas that are outside of the 500 meters. So you can see that, over time, health changes quite a bit year to year for a variety of reasons. The population is aging, there's mobility in the population, maybe the environmental exposures are driving it as well. And then the red line shows us what our group of people living within the goods movement corridor would have experienced if there had been no policy to reduce emissions and improve air quality. And what you can see is that they follow a very similar pattern to the people in these control areas, but they started with higher rates of asthma and they end up with higher rates. And this is just showing the statistical uncertainty, those little bars around the line. The blue is what we see actually happened in these corridors, and that is that the asthma admissions to hospital went down. And they went down to the point where by the end of the follow-up, so some 4 or 5 years after the implementation of the policy, there was no significant difference between our control group, which started with much higher rates of asthma, and our group, not our control. There was no difference between our intervention group, those that benefited from the goods movement policy, from those that were living more than 500 meters away from a goods movement corridor. So this really was a very successful policy in the sense that it drove down rates of asthma in disadvantaged communities. It made a big impact on health disparities. So we no longer see significant disparities between the control group that lives more than 500 meters from the goods movement corridor and those that live within it. And we think that that type of illustration is very important for several reasons. And one of them is it's very tangible and can be illustrated. But secondly, you can see that these rates move around a lot year to year. And if we don't have a control group that's properly specified, we may run the risk of saying, well, the policy's not working because we still see rates going up or going down. Maybe it's working really well, but a lot of that could be happening by chance, not because of the policies that are designed to protect public health. I just want to invite Dr. Molitor in to add anything that I may have not covered as clearly as I should have.
No, Mike, I think you're doing a great job. I'm not really that necessary. But I think, yeah, one of the big criticisms of any kind of air pollution or any kind of policy studies is people will talk about how the policy was implemented and how health outcome changes, or they change, and then people often want to attribute that change entirely to the policy. But of course, there's a ton of other things that could be going on at the same time. In an RCT, a randomized controlled trial, you would have a control that, and you randomize and things like this. Here it's the same idea. We use a control to say, this is what we observe with policy, in the goods movement example. And we use the control to say, what would we observe in the absence of policy? And so that's very important, because then you can ascertain if any reduction, in this case in the ER visits, is due to policy versus all sorts of other things that are going on at the same time. And the control teases out all that other stuff and allows us to focus just on the effects of policy. So for AB 617, if the policy is designation of AB 617 communities, we can try to examine what the effect of that policy had on the health outcome, and not just say the health outcome changed, but what percentage of that change is due to the AB 617 designation, and what percentage of that change is due to exogenous or other factors that may have nothing to do with that policy intervention. So it it's very exciting methodology. People love it because it's you can map things, and it's very intuitive and very clear. And people like it a lot more than putting a whole bunch of data in some crazy complicated multi-level statistical model, which I enjoy doing, but people find very unconvincing often because they don't understand the models. This approach captures some of the same ideas, but does it in a very, very intuitive manner, which I think a lot of people who are not mathematical analysts find quite appealing.
Thanks, John. That was terrific. Next slide, please. In choosing these interventions, there are several criteria that we've developed so far, and that we'll refine as we consult with community members and with ARB and other local air board staff. So one is that the policy has to be implemented in a temporally consistent manner within a relatively short time period. So one of the reasons that we were able to detect effects from the goods movement plan was that they happened virtually almost all within a year. So they're temporally consistent in a short time period. We looked at some of the other emissions reduction programs that were part of the Assembly bill that empowered air boards to start having improvements that were going to be partly funded by the cap and trade program under the Assembly Bill 32. And there was a program there to reduce emissions from boilers that are used in industrial processes. But when we consulted with local air board staff and with Air Resources Board staff, they said, we don't think this is that good a program because it was implemented over a long period of time. And there were a lot of places that had already done these boiler emissions before the program came into effect. And therefore, we don't think that it's necessarily what you're going to see from this program is going to be a clean example of what the policy could do. A second criterion that we have to look at is whether or not it affects a large enough population to apply these elegant statistical methods and derive results. So there could very well be a lot of interventions that are quite local, but we would not have enough of a sample to be able to statistically differentiate the two groups. And the example I showed you for the goods movement corridor, we had more than 25,000 people involved in that sample. So we had a lot of power to show that the intervention group was actually getting healthier compared to the control group. So that was an important component of the evaluation. And that the intervention has been, the third criterion is that it's been actively implemented for some length of time that will result in measurable health benefits. So with the goods movement plan, it wasn't really until year 4 into year 5 that we began to see those really big effects where there's no difference between the control group and the group that was benefiting from the new goods movement plan. Something like the South Coast Air Quality Management District's warehousing rule is a very interesting approach to controlling air pollution that's coming from logistics facilities, which have become so big, particularly in the COVID era where online shopping went up so much. But it's not been implemented for a long enough period of time where we would think that there could be health benefits and emission reductions that would accrue from that. So, and then the next criterion is that there must be a an intervention that can be clearly identified as an intervention group that's benefiting from the regulation and a control group. So this can be complicated because, in our case with the goods movement corridor, we did have some spillover into our control group because some of the emissions that come out of goods movement corridors are precursors to secondary pollutants like ozone or more regional pollutants like PM 2.5, particulate matter less than 2.5 microns in diameter. So when we didn't have a lot of that spillover, but there could be many other types of interventions which are really going to affect broadly most of the population. So we would not be in a good position to identify that intervention and control group. And of course, we want these interventions to be of interest to community members and to the Air Resources Board. So we're not going to just go and academically try to pick out the best policies that satisfy our scientific curiosity. We want policies that are going to be things that people are really interested in knowing. Is this helping the health of people in our community? And because the COVID-19 pandemic had such a devastating effect on the population, and not just for people that got COVID, but the Department of Public Health has done some interesting studies that show that the rates of death that went up, so-called excess mortality, were much, much higher for some groups, like Latinx people. Their rates went up by almost 35% in 2020 compared to the year before the pandemic. Some other groups, it only went up 12 or 15%. So we don't want this evaluation of the intervention to get convoluted in with everything that went on during the COVID era. We're certainly going to take data as it's available and put that into the tracking system and show what happens to many of the health outcomes during the COVID pandemic. But for our evaluation of the intervention, we feel that would really could lead to spurious results. Next slide, please. Okay, I'm going to turn this back to Dr. English, who's going to explain the web-based dashboard that we're working toward.
Yeah, thanks, Mike. We just have a few slides left. So this is just a screenshot of the Tracking California, our existing web portal, where you can already see some of this data. It's not modeled in the same way that that Dr. Molitor was showing you earlier, but this is, for example, showing emergency department visits to asthma for 2020. And you can see that we do already have this data at the zip code level, and you can see the age-adjusted rates per 10,000. Next slide. And this is work that we've been doing with some of our other community partners. This shows you an idea of a kind of a dashboard. This is looking at methane monitoring using data from an experimental methane monitor that we've worked on and did some testing on. So you can see how we can have a screening tool that you can visualize the data, and this is kind of a dashboard similar to what we'd be putting together for tracking these health indices over time. Next slide. So these results, this dashboard will be presented on our website, as I said, and it will be updated over time. And we'll be also submitting documentation of the methods for data updates and the code and a user's manual as part of our deliverables. And we'll also be having a community peer review of the project results, including the final list of selected community health metrics and health report cards, and then any peer-reviewed manuscripts that we come up with. So I think that's it, Mike, on our slides, if I'm correct.
Yeah, I think that's right. So I want to thank everyone for helping to organize this webinar, from the ARB and from Comité and the Public Health Institute and UCLA. And I want to thank you for taking the time to listen to us. And we'd be happy now to take the rest of the meeting to address any questions or concerns that you might have at this point.
Great, thanks everyone. Pat, could you bring up the last 2 slides, please?
Yeah, I'll try to do that.
So just real quickly, I'm Holly Jessup, the contract manager at Carb. For the next steps on this project, as the investigators have mentioned, there's going to be some community engagement and outreach with some regional meetings, and there will also be some quarterly progress reports coming up pretty soon. So if you'd like to receive updates on these meetings or reports, please email me or put your email in the chat on this meeting. Next slide. So now we have about 20 minutes for question and answers. If you have questions, please go ahead and enter them in the chat. And if you'd like a written response, please include your email. We've received 3 questions so far, which I will relay to the investigators. The first is from Jesse Marquez, Coalition for a Safe Environment. They're asking if you could please define what you mean by interventions.
Yeah, that's a good question, Jesse. Nice to see you virtually. Essentially, the interventions are policy actions that are taken by the Air Resources Board or local air boards with the intent of improving air quality. And that could be something statewide, like the Goods Movement Action Plan. It could be something that's specific to some of the AB 617 communities, like measures to reduce idling around the ports. So we consider any of those policies and programs that are aimed at improving air quality to be the intervention. And then also from there, it would have to meet with some of those criteria that I mentioned to qualify as an intervention that we could actually evaluate.
Great, thank you. Jesse would also like to ask a question directly, so I'm going to go ahead and unmute them. Jesse, if you unmute, please ask your question.
Okay, hello, thank you. Thank you all of you, for the work that you're doing, masterminding, what type of actions we can take in the future. But, I'm from the show me state as well over the years, and I've lived and am currently, working on various policies that have been adopted. But then, hey, let's not BS. These are some of the facts that we need to address. And if your health thing that you're going to be proposing, this assessment is going to be a total success, then we need to plug in all the things that are going to close all the loopholes. Yes, AB 32 has specific policy, but what the ARB adopted and what the ARB board adopted was influenced by the petroleum industry, the chemical industry. So I can tell you right now, it's an absolute failure. I live in a petroleum community, 4 oil refineries, and numerous other petroleum facilities. In all this time of that cap and trade, there has been no significant reduction in any air emissions from these industries. That is a problem because it is a policy that's not working. Another example, Alameda Corridor. We were invited we were questioned, we were discussed, we were wined and dined by every government agency, the ports, freight transportation, you name it, to support the Alameda Corridor because it was going to be a bond. And we accepted it as a public because we knew it was going to cost $1 billion with the promise it would take trucks off the local freeways. Well, in case no one's paying attention, the Alameda Corridor project is a complete failure today. A complete failure last year, 5 years ago, and 10 years ago, because it's a policy that was manipulated. Only Port of LA and Long Beach commissioners sit on that board. And they have no intentions to want to reduce anything. Why? Because they listen to the shipping industry. So there is no requirement in the lease agreements that port shipping terminal, you will reduce, you will use it. 10% this year, 15% next year, 20% in 5 years. So there is no mandate to use it. So today it's operating at about a 35% capacity, the same as 5 years ago, 10 years ago, 15 years ago, and it's in the red, losing money. Why? It's not being used. So while we're talking about interventions, let's also be up front and list what has caused the failures of these different types of interventions, because many of us can go into detail as what's causing a problem, what's causing a failure. I do not want that to happen in what you're doing. And yes, having Luis there as a community representative is a great opportunity and a great participant, but you need to also have a few more that are not going to hide behind anything, that are be point blank and state what are the problems. Because yes, I see your data showing, that emergency visits has increased, but it's too large an area. What we, the EJ movement, has proposed the last 15 years is a health impact assessment of every policy and a public health survey so that you can establish a public health baseline. Another good example, the governor issued an executive order to waive shore power from ships. Well, he did not consult with any doctor, any health department, any agency. Oh, would this policy have any effect on the public? Well, it did. Sunday night, I was rushing at 8:30 at night with an acute asthma attack because wildfires combined with taking off the shore power now and having 30, 40 ships, putting out 2-3 tons a day, not counting those that are outside the breakwater. These are some of the things that we need to include in your assessment and your evaluation and your planning. And
Yeah, I
so
think
I'll
that,
stop there and I'll provide written comments in other respects. Thank you.
Okay, thanks so much, Jesse. I think that, setting that baseline of health and doing these indicators is going to help quite a bit. And I think that your points are really excellent about why are there gaps in implementation, and why do we see some of these policies just not being implemented when they've been put forth as something that would be. And I think it's very important to understand that aspect of it as well. And certainly during the public consultations, we'll be looking for input from you and others that will help us to identify those. But I think that, we're not going to be necessarily able to look at a huge array of different policies. So we're going to try to look at those that have been implemented and try to see whether or not they have benefits. But all of your points are, very valid and something that we can put into our consultative process and to see if there are ways that we can evaluate those types of policy failures as well.
Yeah, I just, want to say, if I could interject, as someone who's going to be heavily engaged in analyzing policy effectiveness. I mean, I come from the Show Me State as well. My whole family's from St. Louis, and it's quite true that people in Missouri have a low tolerance for bullshit, pardon my language. But I don't work for the petroleum industry. I have no interest in advocating for big corporate interests. My job is to work with people like Dr. Jared and others to scientifically assess the effectiveness of these interventions without pushing any outside corporate interests. So just keep that in mind. Nobody's pulling, nobody has my ear. And all we're trying to do is assess the effectiveness of these policies in the best scientific way that we can.
Yeah, and I think that, Jesse was making a good point that some of these policies don't happen in the way they should because there are a lot of different and conflicting interests, and that's certainly something that needs to be taken into account as we go forward. But this will certainly give you a much better baseline of health information than what we've had in the past.
Thanks,
Dr.
Jesse and Dr. Jarrett. If I may, we have a couple of other questions.
Okay.
Another has come from Denise Curry. She asking, what about adding infant mortality? This data is collected at the county level already.
I could maybe address that, Mike, if you want me to.
Yes, thanks, Paul.
Yeah, so yeah, we certainly can consider infant mortality, especially if that's a community concern. Actually, what we have available is we have geocoded information at the address level for pregnancy outcomes for every woman in the state. So we can look at that at a much more local level than county. The one thing I would say about infant mortality is, remember, we were trying to look at health outcomes that are proximal to the exposure. In this case, we're looking at air pollution. And there certainly is literature on air pollution and reproductive health effects, whether they're infant mortality or preterm birth or low birth weight. But this, I would say it's not as proximal as something as like asthma exacerbation. So, in our initial prioritization, that wasn't identified, but it could definitely be included. Thank you.
Thank you. Another question that we have is from Andrew. How does emergency department data compare to survey data for these health outcomes? Is it comparable at these scales? Is the California Health Information Survey available statewide? And how does that compare to something like the CDC Places census tract or zip code estimates?
I'm gonna take a shot at that too, Mike.
Sure, Paul. Yeah, I'm happy to jump in too.
Okay.
But please go ahead.
Yeah. So the emergency room and hospitalization data, the main one of the big advantages of that is it's supposed to include everyone that's gone to the ER or admitted to the hospital, everyone in the whole state. The survey data like CHIS, they do have a neighborhood level product now, and how that's different is it doesn't give you information on it focuses, say, on symptoms, so it's a different measure. And also you have to think about the number of people that they survey. So when you get down to the lower level, there may be, because of smaller numbers, there may be variability in the estimates. So they're kind of different. I mean, we definitely are thinking about using the GIST data, but just so you're aware that they're different types of measures that have advantages and disadvantages.
Yeah. So
what else do you want to add, Mike? I mean, you got, UCLA is GIST, right? So you guys might be a bit more familiar with the weaknesses and strengths.
For health policy research. So, and Dr. Yu is working extensively with the CHIS data. And, one of the issues there is that there are, as Paul mentioned, small counts in small areas. So we either have to aggregate it over a very long period of time or use data that the CHIS people have done statistical algorithms to compute rates, but they're not really true rates as what we would get from emergency room and hospital admission data. They're modeled. And so there are disadvantages to that. And, the CHIS sort of operates on an ongoing basis. every 2 years, there's a cycle. So it's not always temporally very sensitive to what might be going on in relation to emissions reductions and exposure reductions. Dr. Jessup, are there more questions?
Actually, this is Pat. We have a participant with her hand raised, and
Yeah.
those of you who would like to also ask a question orally, please raise your hand. We're going to go back and forth between the chat questions and participants. So I think Lily Wu has her hand raised.
Thanks, Pat.
Is it okay? Thank you for your very helpful presentation. I thought you touched on a lot of complexities of trying to do this work and trying to find a SERP intervention that might be a health benefit for any AB 617 communities. I am a community air protection toxicologist with OEHA, and I work to support Carb's AB 617 program. I have the benefit of having an overview understanding of many of our 617 communities, and I see our Central Valley Air District, some colleagues from there too. One of my things that I notice is that in trying to compare like such a large data set with another large data set, you lose sensitivity, as was mentioned, with like a temporal finding of like, if, for example, air filtration is given to a certain population, will you see a reduction in asthma rates? Those are, I think, as a health toxicologist, two complex problems. PM 2.5 is a complex mixture, and say, for example, PM 2.5 from Imperial County would be very different than PM 2.5 than, say, like from a community like Arvin, Lamont. Given that there are large kind of categories of emission sources like refinery or pesticide, have you guys thought about trying to compare data from different communities with different profiles? For example, like Richmond, San Pablo, which is a very oil refinery type community, with like an agricultural community that also has oil refinery like Arvin, Lamont, and then trying to see what is similar and different given what overlaps and what doesn't overlap.
Well, thank you. So you mean in terms of the emissions and exposures, or in terms of the health tracking?
Well, so that is the complexity of it all. So I think of it from like the health endpoint and trying to just get my data set smaller. So PM 2.5 is too complex of a mixture to try to say like one particular pesticide in that complex mixture might cause, for example, asthma, but it could also certainly cause certain other things, many other things. And then so because asthma is such a condition that takes long to develop, and people might be more vulnerable than others given non-chemical stressors, such as like just the community accessibility to healthcare or other social constructs. And so with that, trying to think of like how to make a smaller comparison with an intervention with a smaller comparison of a pollutant.
Yeah, I mean, I think that's very well taken point, that there are going to be these source signature differences, and some of our indicators where we have monitoring data are fairly crude and they're multi-sourced, and they're going to vary quite a bit from place to place. So those will be the types of things that we would really be interested in talking to you and others about as we go through the consultation, to try to come up with some appropriate comparisons that are going to show us what's going on in communities that have different source signatures. We will have all the data, but then this sort of ends up being, a bit of a comparison between communities. We want to try to specify our control groups very precisely. So, what you're suggesting might be really good in a sense that we could focus on sources and look at differences over time between communities that were dominated by different types of sources. And that's another way that we could apply the quasi-experimental modeling. We haven't really come to that conclusion yet, as we wanted to find a specific set of interventions, but that would be another way that we could usefully employ some of these advanced methods that Dr. Molitor is developing.
Just I appreciate that feedback. Just one more thing to offer. There are other branches of science like exposomics, for example, where we take large data sets and try to use different approaches, targeted and non-targeted, and then kind of piece it together with like mode of action, what we know about certain chemicals and the health outcomes that come from that. So if there's a way to complement what is happening with your modeling and your data finding of comparisons of communities and pollution sources, I'd be happy to help continue that conversation.
Okay, well, that's great. We'll look forward to that as we get into the consultation, and we'll make sure that you're invited.
Thanks, Lily. And we have about 5 more minutes. We have a couple more questions. There's another one from Susan Hurley. They say it sounds like the rates will be age standardized. Will rates not also be adjusted for race ethnicity? Is it an issue of small numbers? That is, how do you plan to account for racial ethnic differences and factors such as access to care in your comparisons of ER asthma rates?
Yeah, well, we just used the asthma rates as an example. So we'll be doing this for many different outcomes. We can adjust for age, race, gender. All of those are questions that we want to talk to the community about in the consultation. It's true that as we start slicing the data more finely, what will start happening is that we'll get more of those suppressed cases and we'll lose the data. So we'll have to use a longer run of data, many more years, to get to the point where we don't have the data suppression issues. We looked at working sort of what Dr. English calls behind the firewall, and his group, it can be accessed through a long and arduous process to get to the actual individual level data. So you could do all of those types of adjustments for every racial or ethnic group. But the problem is then it's not very sustainable, so that what we're trying to do is to take data that's publicly available or can be easily assembled based on public sources that we can then work with. So it's sort of a trade-off, the sustainability of the system and how much more refined we want to get by looking at different controls. But certainly we can control for age, race, gender, age, looking at different geographic regions. There are many things that we could do. And as we go through this, if that turns out to be something that's very important to people, we'll come up with the best analytic approach to handle that. But that might involve using data that's behind the firewall, and then sustaining the system in the future would be in question. So that's really what we're trying to do, is get a balance between what's sustainable from the public sources and what is something that would meet absolutely every standardization criterion.
Thanks. We were speaking earlier with Lily about triggering asthma, and Luis Olmedo of CCV has commented that one exposure could trigger asthma even in the undiagnosed. And he asked, did I hear correctly that it takes over time exposure to develop asthma?
Yeah, so there are instances of people being exposed to very high levels of certain contaminants in occupational settings where they have, instant onset asthma as a result of that exposure. And Dr. Baums is an expert in all of the various occupational exposures, but normally we would not see it in the environment where the levels don't tend to be as high, one exposure causing that incident onset of asthma. That one exposure could certainly cause an exacerbation of asthma in somebody that's already an asthmatic, but normally it takes several years of sustained exposure to contribute to asthma formation.
And I noticed Luis does have his hand up. Luis, would you like to add any more to your comments?
Yeah, thanks. No, that was just since that I had heard Oika said that it takes time, but I know that there are scenarios where it may not take time. Maybe you've never had asthma. Well, you describe it very well, Dr. Jared. That's that was just wanted to clarify that, because if I heard it correctly from Oika, it sounded like there is no scenario where someone would develop the onset of asthma with one bad exposure.
Yeah, I think there are these occupational exposures that could do it, but in the environment, I'm not aware of, even during wildfire events and that sort of thing, where levels get very high, of that kind of instant onset.
Great, thank you. Well, it looks like we're at the end of our time.
Yeah, it looks like Bonnie did have a question in the chat. Maybe
Bonnie,
perhaps, well, if this is a quick answer, if we can, otherwise.
I think it's a quick answer.
Okay,
I think it'd be helpful just put in the chat, just
Yes.
if you could provide any more information on what communities you're going to prioritize for these initial conversations, meetings within the areas that you showed us in Southern California, Bay Area, San Joaquin Valley, or if that depends on further conversations with the community. Thank you.
Well, Bonnie, we mentioned some of the individual organizations, I think earlier, such as members of the ARI Collaborative, but we haven't developed the outreach and communication plan yet. So that's going to be all detailed in that plan, and once we have that, we'll be able to send that out for people to look at and comment.
Okay, so we'll be discussing that in the next quarterly update. Sounds like.
I hope so.
Thank you. Awesome. Thanks for the excellent presentation and discussion.
Yeah, well, thank you for the opportunity to conduct this research and really important project to the residents of California. So we're really looking forward to working with everyone as we go through this and producing some results that can be used by the communities to better advocate to protect their health.
great, thank you so much. It was excellent presentations, and thank you for excellent questions. If we did not get to your question, I will be emailing you. If you have put your email in the chat, I will be adding you to updates on this project. And I think that's everything. So thanks again, and we look forward to seeing you at the next update meeting for this project.